cells from the one lineage to the other lineage. So here this picture shows the presence of this different antigens on the cell membrane, or is in the nucleus, or in the cytoplasm. So we have different techniques to detect all these, even in the intracellular antigens. So here they have a different, neutrophils have the different set of antigen positive, whereas the immature cells are having a different set of antigen positive. Even it's not only these, immunophenotype helps to differentiate from different lineages, it helps to differentiate the mature from the immature cells. So this is, if we have done this immunohistochemistry, this is how the slides looks like. Here you can appreciate there is some sort of a color outline the cell membrane. So this is the cell membrane positive antigens. Here you can appreciate it. So this is how, when you do an immunohistochemistry technique on the trephined tissue or a histology tissue, this is how this is normal HNE stain, but when we stain with this immunohistochemistry technique, you can see the color difference, and this is how this looks like. So this is flow cytometry. So flow cytometry is a machine, you run the specimen through this arm, and it will analyze each cell one by one, what sort of a cells it looks like. So it gives a plot or a graph like this. Then by looking at this, we can interpret the cells which lineage they belongs to. So this is a bit of a to understand how the flow cytometry report comes. Here you can appreciate this this is a CD45 marker, and this is a site scatter, and here CD117, here the CD34. So here you can see these cells, we call that as an event. So if one cell goes through the laser beam, then you will get the event, one event. We call that as one event, and that will be detected by the detector in the machine. Here, these cells, here if these group of cells, CD34 negative and CD117 negative. This group of cells, CD34 positive, whereas CD117 is negative. This group of cell is CD34 positive and CD117 also positive, this group. And here, this is only CD117 positive and CD34 negative, because this x-axis here shows the CD34, here y-axis shows the CD117. So by looking at this plot or a graph, we should be able to say that particular abnormal population here, what are the antigen they express. Depending on that, we should be able to say whether this is a myeloblast or a monoblast or it's a lymphoblast. So here in this axis is a CD2, here this axis is a CD7. So here these group of cells, CD7 positive and CD2 negative. So here it both positive, CD7 positive and CD2 positive. So that's how you interpret the plot or a graph that we'll get it from flow cytometry, and that helps to say whether there's an immature or a mature malignancy, and whether it's a myeloid or lymphoid or which lineage they belong to. So this is a question. So here the CD19 is an antigen on B lymphoid cell. So we use this CD19 to differentiate the B lineage cells, and CD3 is used to differentiate the T cells, because this is positive in T cells. So this is T lineage cell and this is the B lineage. So here we have run the peripheral blood of a patient, and this is how the flow cytometry, it gives the report. Can someone say whether there are more B cells or T cells? And you have to explain me why you have said this, which is predominant cell. Can someone tell me?
Cells from the T lineage.
Why did you say so?
Because they both the B lineage cells and the T lineage cells share a common area, which is at the left.
So
which is the negative.
So there is so this is there is a negative. So it doesn't this particular cell doesn't express either 19 or CD3, isn't it? So there are group of cells CD19, and so do you think the T cells is predominant here?
Yes, ma'am.
Yeah, so why? Because you can differentiate by looking at there is a more cells here compared to the cells here. So here, CD19 positive, CD3 negative. Here, CD3 positive and CD19 negative. Here, both are negative here. So out of this group, here is the more cells falling into this bundle. So here, so as she mentioned, mainly the T cells are predominant here. Very good. And can somebody interpret this? This is a bone marrow sample of a 4-year-old boy. When we have seen the morphology slides, it looks like 80% of blast. So then we have done the flow cytometry on the sample and what the expression is. Can someone tell me the answer?
Both CD10 and 19 positive.
Yeah, so because in this group of cells, it's both positive, 19 and 10 positive. So the answer is both CD19, 10 and 19 positive. So then we call that as a B lymphoblastic leukemia because we use 19 to say it's a B cell lineage. And 10 is used to say it's an immature cell. So then we call this a lymphoblast. Okay, so that's how we come into diagnose by using the flow cytometry or flow cytometry. So up to now, we have studied the morphology and cytochemistry, immunophenotyping, and now we'll move on to genetics. So there are several techniques or several methods we use to detect the genetic abnormalities. So this is, we call this a karyotyping or the conventional G banding technique. This is how the karyotype report looks like. So here 46 XY. So then we know this is a male. And can you all appreciate here? There is the chromosome 9 is a bit longer than the partner one. And whereas the chromosome 22, here the shortage compared to the other partner of 22. So then we know there is a translocation between 9 and 22. So that's why the report says, so the translocation 922. So then we know this karyotype, the male the male patient having a translocation of 922. So that's how it helps. The karyotyping technique also helps to look for any translocations, any deletions. So, and we can appreciate if there is an extra copy of the chromosome. For an example, in Down syndrome, you can see the chromosome 21. Here, there will be another chromosome here. Then we call that as trisomy. So that's how we look into the karyotype to look for any abnormalities in the genetic aberrations. So not only the karyotype, there's the other technique we call that's a PCR. So that also helps to detect the mutant abnormalities in the genetic derangements. So there is you all must be knowing a technique how they do a PCR, because they usually, in the biochemistry, they teach you all how to do the PCR. So I'm not going to teach on the how to do a PCR, but I just wanted to mention here the PCR also is a technique is used to detect in the genetic abnormalities. So not only that, there are other tests as well. We call as a FISH, fluorescent in situ hybridization, and the other advanced genetic testings are next generation sequencing and whole genome sequencing. So in Sri Lanka, here the next generation sequencing and FISH are carried out in the private sectors, but PCR and karyotyping, even we can get it in the genetic lab, but here in the Faculty of Medicine as well. So because these are very expensive, that is more help or more narrow down your diagnosis, and also it helps in the classification of AML. As I have mentioned previously, under the WHO classification in 2016 of AML, they mentioned the genetic abnormalities also is one of help to subtype the AML. So that's because these genetic tests have been carried out. So this is, I just wanted to show you all the acute promyelocytic leukemia. Out of AML, acute promyelocytic leukemia is a bit of an emergency in the hematology field because the patient will present with a DIC and other sort of complications. So, and also high mortality unless if we treat the patient as soon as possible. So in the APML, the simple karyotyping test helps for detection of translocation 1517, and most of the time people tend to do PCR or FISH in order to diagnose it, because those are relatively quicker tests and we'll get the report as soon as possible, because we have to treat the patient as soon as possible in order to prevent mortality due to the condition. So this is one of a special condition out of AML. So usually as a clinician, we tend to diagnose by just looking the blood film or a morphology appearance of the cell. So we have to master in that looking at the morphology. As I have mentioned, this is one of a hematological emergency. We can't wait for these genetic tests to come because that will take a time, whereas the blood picture we can see within an hour and we can diagnose at least a 97 to 98%. We can confirm that it's definitely it could be a APML. This is just to show that how even in the diagnosis of APML, the cytogenetics is help, and the FISH studies and PCRs are help. So in the management, is briefly, I have mentioned the management of AML. So supportive care. So as you all know, under the supportive care, we tend to give blood transfusion if the patient's hemoglobin is low and the patient is having symptoms for anemia. And same equally, we give platelet transfusion if patient presents with any bleeding manifestations, or if patient presents with evidence of DIC, or if patient is waiting to have any procedures, or if it's sepsis, then we give the platelet transfusion for that patient. So under supportive care, we tend to discuss about the component transfusion, and not only the transfusion, and sometimes we have to start on prophylactic antibacterial treatment, because as we know, neutropenic is risk of having infection. So specific treatment, we give chemotherapy. So there are several regimes of chemotherapy. It depends on the type of leukemia and we give induction and the consolidation. That's how the chemotherapy regime goes. So at your level, if you know that if patient comes with an acute leukemia, you should be confident enough to manage the support. You have to provide the supportive care to the patient. This chemotherapy, and and usually we give the chemotherapy. If you know, just keep giving a chemotherapy, that would be enough at your level. And there are some targeted therapy as well, as I have mentioned. The immunophenotyping is very helpful in order to identify the abnormal cell, what are the antigenic express. So we can target the therapy for that particular antigen and we can kill the abnormal cell. So that is meant by the targeted therapy. And at last, in order to cure the disease, then we have to go for the stem cell transplantation. So in summary, we have studied about hematological malignancy. There is myeloid and lymphoid, and you can divide it into, it depends on that, how with the proliferation, or if it's a minimal proliferation, you divide it to AML and the myeloproliferative neoplasm. Again, in the lymphoid, there will be mature lymphomas and precursor lymphoblastic leukemia. So this is a brief outline of hematologic malignancy, what sort of a malignancy that we come across in the hematology, mature and immature. And here also mature and immature, it depends on which lineage is involved. And always in your level, you have to remember that we call acute leukemia when there are blasts more than 20 in blood or bone marrow. And the diagnosis, so we discuss about the morphology, how it helps for narrow down your diagnosis, and the cytochemistry, and also we discuss the immunophenotyping, that we can do either immunohistochemistry in the tissues or by the flow cytometry in the fluid, when the specimen is fluid. And equally, the genetics is playing an important role in order to diagnose as well as classify or categorize the subtype, the AML. The genetics is playing an important role. And not only the cytogenetics by karyotyping, but also the molecular genetic studies by PCR, FISH, and also the other next generation sequencing and whole genome sequencing. Treatment, we have studied about the combination of drugs, but at your level, you should be able to describe or more elaborate more bit about the supportive care. Because once you become an HO, once you have finished, once you graduated and you got your MBBS degree, then you will be start to do the internship where you will be the first medical person encountering the patient. So you should be able to arrive at the certain, at least a differential diagnosis, and you should be able to know how to manage the emergencies or how to give the supportive, because you don't need to wait until consultant or some senior people to come and say, give the blood to this patient. Because you know, if the patient having anemic symptoms and the hemoglobin is low, then you should know that the patient has to be given the blood transfusion. So that's why we actually teach all these conditions in order to understand the pathogenesis, how the disease occurs, and how the patient can present, and how you will diagnose it, and how you will treat the patient. Okay, so this is end of the lecture. Do you all have anything to clarify or anything to ask?